Hi, my name is Margot Kushel, and I'm happy to be here with you all today to talk about homelessness and COVID-19, a crisis upon a crisis. Next slide. The COVID outbreak has really created a major crisis for America's homeless for a variety of reasons that I would love to talk through today. Next slide. To lay out what we think the problem is, I'm having some trouble with my slides here today. To lay out what we think the problem is and has been with homelessness and COVID, the first we knew right from the first reports of COVID coming out of Asia, we began to worry that the homeless population would be at very high risk of both acquiring the disease or transmitting the disease because of the nature of how people experiencing homelessness are forced to live, either in congregate shelters, encampments, the use of free or low-cost food lines, social services, the lack of hygiene. These were all setups for major problems. We were concerned about health-related behaviors such as substance use or tobacco smoking that may complicate the ability to partake in activities to reduce the risk, like wearing masks. We knew that amongst people experiencing homelessness, many are essential workers who would be at high risk of acquiring the disease. And we were concerned about the cross-transmission between jails and prisons and homeless shelters or people experiencing homelessness. We also, as time went on, became more concerned about the difficulty of this population to access testing, as well as the difficulty of following up once people receive testing. We knew that this population would lack places to safely isolate and quarantine. This could not only put them and others at high risk, but could put extra stress on already overstressed hospitals, as well as increasing the community transmission of the disease. Next slide. We knew that people experiencing homelessness would be, and in fact are, at high risk of poor outcomes were they to be infected with COVID, both because of their older age, co-occurring medical conditions, and poor access to timely testing, as well as healthcare. We have been concerned about the loss of infrastructure to ameliorate homelessness, the effect of the pandemic on things like shelters, libraries, free and low-cost food lines, and other services that people experiencing homelessness rely on. We're concerned about the lack of uptake or distribution issues with the vaccine when it becomes available. And finally, we're extremely concerned about the increased risk of homelessness due to economic disruptions. In this talk, I want to just briefly outline some of those concerns and some potential responses that have happened or that we hope to happen. Next slide. So first of all, a high risk of COVID transmission. Next slide. So we know that congregate settings increase the risk of acquiring COVID. About 2/3 of people experiencing homelessness live in congregate shelters. These shelters offer little ability to social distance, poor ventilation, the use of shared bathrooms. And also, once we realized that masking was incredibly important to reduce the risk of spread, it's a very different thing to wear a mask when you're outside your home, or to wear a mask 24/7 if you live in a congregate setting. Next slide. We are concerned and remain concerned, and there's increasing evidence that some health-related behaviors that are common in people experiencing homelessness may increase the risk of COVID acquisition. For instance, there's now suggestive evidence that smoking, alcohol use, and illicit drug use could increase the risk of acquiring COVID, both because of shared activities and close contact, because these activities often decrease the ability to wear masks and decrease the ability to adhere to other prevention activities such as social distancing. In a study we've recently completed in older homeless experience adults, we found that people who reported being a heavy drinker or using illicit drug use, both of these things were strongly and independently associated with a decreased ability to social distance. Next slide. I think something that has been perhaps less well reported on and less well appreciated is the convergence of frontline essential workers and homelessness. As one of our study participants said, describing how they go from their work in a fast food restaurant back into their encampment, I work in a public place, so, I can't help from interacting with the people. The law says you have to wear a mask inside, meaning inside their fast food establishment. So I try to get it enforced where people do what the law says, but you're always going to have a hothead or a rebellious guy, and they just ain't going to do it. We have seen that the COVID pandemic has really been fueled by those, or really experienced most by those who are frontline essential workers, often low-paid workers, living in crowded housing. That story has been told quite well. I think what has been less appreciated is how many of those essential workers are actually living in homeless shelters or encampments, and really bringing that risk home to where they are. Next slide. The other point that I think always bears worth mentioning is the association between carceral settings and homelessness. We know that about 50,000 people each year enter homeless shelters immediately after exiting incarceration. 15% of those who are in jail were homeless in the year prior to jail admission. And we know that even more so than homeless shelters, jails and prisons have had some of the highest rates of COVID transmission. This interchange between people exiting and entering carceral systems and homeless environments has really been a cause for concern in fueling the pandemic. Next slide. We have seen some terrible outbreaks of COVID in homeless shelters, as we were concerned about, as we anticipated, and in fact, as has happened. Next slide. These are from some reports from the CDC. This was a study of 4 different shelters, outbreaks in 4 different cities, but in multiple different shelters, where they found after 1 or 2 cases were reported, outbreaks that encompass between 17 and 66% of all shelter residents at the time of the outbreak. This is an incredibly high rate of transmission and an incredibly concerning issue. After these were reported, there have been shelter outbreaks reported in many cities across the country. Next slide. Across 19 shelters in 4 cities, there was an overall 25% positive rate in homeless residents and an incredibly high rate of 11% among staff members. In one outbreak in San Francisco, it's notable that half of the people who were found to be infected after there were a few cases identified were asymptomatic at the time of testing. A quarter had an underlying health condition, and 21% were older adults. 8% of all of those infected required hospitalization. And of those infected, it was about 2/3 of all living in the shelter were infected. 8% of shelter residents wound up requiring hospitalization. Next slide. In New York, there were, and this is thought to be an undercount, there were a little while ago, 1,400 known infections and 104 known deaths amongst people experiencing homelessness. But I think the more important thing was that they noted a 67% higher age-adjusted mortality rate than they saw in the general population from COVID. Next slide. We have done some modeling work to look at the impact of various risk reduction strategies to reduce the risk of shelter residents. We examined, built models based on a variety of outbreaks across the country, and we modeled different strategies: daily symptom screening, twice weekly PCR testing, which is the standard of care testing for COVID, universal mask wearing, relocating high-risk individuals, or a combined strategy that included daily symptom screening, twice weekly testing, universal mask wearing, and relocating high-risk individuals. I think the really disheartening part of our exercise found that even if you could do all of those things, which I want to reiterate are extremely hard to do, I've heard of very few shelters, or really none, that have been able to operationalize twice weekly testing. It's expensive and it is logistically difficult to do. Universal mask wearing means that people wear masks 80% of the time. And again, I'm not wearing a mask when I'm speaking to you from my house, and you're probably not wearing a mask in your house either. This is a very high bar of activities, but even with all of these strategies together, assuming that there was a moderate risk of community spread in your community, so that communities were not in the hot zone, but were in sort of moderate zone of community spread, one could only reduce the risk of an outbreak by 40% by combining all of these activities. What this says to me is that in current shelters with current ventilation patterns and current amounts of crowding, that even if we did a lot more than what most places can afford to do, if there is moderate or high community spread, as we're currently seeing in most parts of the United States, we can only reduce the risk of an outbreak of 3 or more people getting infected by 40%, meaning that it would be very hard to avoid having major COVID outbreaks by doing these activities. Next slide. Next slide. Other issues that are confronting us or confronting people experiencing homeless are the lack of places to isolate and quarantine. The current CDC recommendations, which may well change soon, is that anyone with a known exposure to an infected person, this usually means more than 15 minutes of contact, less than 6 feet away, is required to have a 14-day quarantine period. And anyone who is actually known to be infected by COVID needs to spend at least 10 days in isolation. This means using their own bathroom, their own bedroom, staying away from others. These activities are essential to decrease disease spread, and while we expect they will be loosened soon a little bit, they have been really the hallmark of trying to prevent outbreaks across the country. Obviously, people who are homeless, people who are living in congregate shelters do not have places to isolate and quarantine. Next slide. We have been concerned about the possibility of worse outcomes with COVID. This is partially because of higher age range of people experiencing homelessness and the known association between older age and worse COVID outcomes. Next slide. And next slide. So the risk for COVID complications increase with age, and the homeless population is aging. This is from a study we published a number of years ago that showed that in 1990, about 11% of single homeless adults in San Francisco were 50 and older. In 2003, 37% were, and now about 50% are. Next slide. My colleague, Dennis Culhane, and his colleagues have shown that this is a generational effect. Americans born in the second half of the baby boom, about 1955 to 1965, have had an elevated risk of homelessness their whole lifetime. So now we are in this bubble of the people most likely to experience homelessness, the single adults most likely to experience homelessness, are right in the age range of people at the highest risk of worse COVID outcomes. Next slide. This trend is expected to continue, and you can see we're right in the middle of this escalation, where the fastest rising group of people experiencing homelessness are actually those 65 and older. Next slide. We know that people experiencing homelessness are disproportionately burdened by many of the comorbid conditions, which unfortunately are the same conditions that increase the risk of death or requiring hospitalization from COVID. Things like cancer, chronic kidney disease, chronic obstructive pulmonary disease, heart conditions, type 2 diabetes, immunocompromising states like HIV, obesity, sickle cell disease, and smoking are all highly associated with poor COVID outcomes and are very common in people experiencing homelessness. Next slide. You can see here that the risk of chronic diseases is much higher in people experiencing homelessness than it is in the general population, whether we're talking about high blood pressure, diabetes, heart problems or stroke, liver conditions, or HIV. Next slide. Perhaps less appreciated are the extremely high risk rates of smoking in the homeless population. An estimated 60 to 80% of homeless adults smoke in the United States. Smoking has turned out to be a major risk factor for poor COVID outcomes. Next slide. We are aware and concerned about the fact that people who are homeless are going to have much more difficulty accessing testing. Testing has been incredibly important for a few reasons. One, it is really one of our mainstays of preventing community spread. This is a disease that is contagious in the asymptomatic state, and so it's really important that people have access to routine screening. And it's also important that people know if they're infected to protect themselves so that they can get timely access to health care. We know that people experiencing homelessness overall have very poor access to ambulatory health care. We know they're much less likely to have insurance coverage, and when they do, it's much more likely to be public insurance. And we know that they have poor access to transportation, internet, and phones. This has turned out to be a major problem on getting access to testing. Many of the current testing efforts requires transportation to get there, requires internet and phone to sign up for testing, and testing is only as good as the ability to get your results. And so what has been found is often testing is done in these populations, but they cannot be located to let people know if they have a positive result. Next slide. We know that the homeless population overall has poor access to ambulatory care and high rates of acute healthcare utilization. For instance, in the general population, about 40% of people experiencing homelessness access emergency department in the prior year, compared to 11% in the general population. This is even higher amongst those who are 50 and older, and we know people experiencing homelessness are much more likely to be readmitted. We've been very concerned that COVID-19 is just going to compound this problem and strain already limited hospital resources. Next slide. Finally, there's no way to talk about homelessness without talking about the role of structural racism in producing it. Because of structural racism, we know that Black Americans are much more likely to experience homelessness, increased rates of about 40% as opposed to 13% of Black Americans in the general U.S. population, and increased rates of homelessness around Native Americans as well. These populations turn out to be the populations at highest risk for poor outcomes from COVID. Next slide. We know that housing problems, essential work, and poor access to care, all of which are components are affected by structural racism, compound racial and ethnic disparities in COVID outcomes. And as you can see, Black Americans, Latinx Americans, and Native Americans have had much higher case rates, much higher rates of hospitalization, and much higher rates of death than white Americans from COVID. Next slide. The COVID pandemic really also worsens the experience of homelessness. So not only are people experiencing homelessness at much higher risk from COVID, but the pandemic itself has really worsened the already horrendous conditions of homelessness. There is decreased capacity of shelters without replacements, leading to increased rates of unsheltered homelessness in much of the Western U.S. Things like the closure of libraries and coffee shops and other areas that are seen as respite for people experiencing homelessness has had a major effect on people's quality of life, their ability to access internet, their ability to find some safety. We have seen a decreased access to free and low-cost meals, worsening hunger, and worsened access to healthcare, harm reduction services, substance use treatment, and mental health care. We have often talked about how so much of healthcare has switched to telehealth during the pandemic. This has not been an option that has served the homeless population well. We've also seen increased rates of social isolation amongst all, but particularly amongst people experiencing homelessness. Next slide. The economic fallout from COVID continues to hit lower income Americans the hardest. We worry that the pandemic is going to increase the already horrific rates of homelessness. Next slide. COVID is estimated to place many, many more at risk of homelessness. And some of the estimates include up to 1.5 million families are currently on the cusp of homelessness due to the economic disruptions of the pandemic. Next slide. So what have been some responses to the pandemic, and where can we go from here? Next slide. First, and perhaps foremost, in terms of trying to prevent inflows into homelessness, have been an unprecedented reliance on eviction moratoria. There's some good news here. The CDC, for instance, for the first time, issued a federal eviction moratorium that had some very good things about it and is in place for another few weeks. However, this only covers those with a legal right to housing. It does not pay back rent, and it only covers eviction related to the loss of income. People who want to take advantage of this eviction moratorium need to attest that they're trying to pay the rent, obtaining all possible support, and would become homeless otherwise. It does not cover evictions for reasons other than non-payment of rent. It does not cover back rent, and it does not prevent eviction process from being started. Next slide. Oops. Can you go to the, there we go. This is what tenants would have to do to be able to take advantage of the moratorium, is they would have to basically attest to all of these things. Next slide. So the eviction moratorium is that is a federal eviction moratorium. There were also eviction moratoriums at the state and local level, which I think I will talk about in a moment. I wanted to review some of the other CDC recommendations. For those in encampments, if individual housing units were not available, the CDC recommended that people could stay where they were and encouraged people to socially distance in encampments. Next slide. Congregate shelters scrambled to do what they could. Many started by doing symptom screening, and while they continue to do this, this has not been shown to be an effective way to prevent outbreaks, in large part because this disease is most transmissible in the 2 days before it becomes symptomatic, and because many people have the disease and remain asymptomatic throughout. Some shelters have managed to do regular testing with either rapid antigen tests or PCR tests. But as I said before, even with twice-a-week testing, which has been very difficult to sustain, it's difficult to prevent outbreaks if there's moderate or high community spread. Most shelters require masking, but again, this is quite a high task to ask people to wear a mask all the time. Many have de-intensified to increase social distancing, and many have tried to remove those at highest risk for COVID complications. Next slide. The CARES Act provided resources to try to ameliorate this pandemic, both through the Community Developed Block Grants, Emergency Services Grants, or ESG funding, and the Coronavirus Relief Funds. These have been an enormous help, but as you're well aware, these funds need to be spent by December 30th. Next slide. Project Roomkey in California was, I think, in some ways, a model response to try to manage the effects of this pandemic. Project Roomkey started being planned in March as soon as a shelter-in-place order happened, where using CARES Act funding as well as California funding, as well as funding from FEMA, high-risk homeless people were offered non-congregate shelters in either hotel rooms, trailers during COVID-19 to shelter in place, with the idea that this would lower individual risk and reduce hospital burden. To qualify for Project Roomkey, you had to be 65 or older and have underlying conditions such as diabetes, cancer, chronic lung disease, liver disease, HIV, smoking, pregnancy, or immunosuppression. Next slide. Project Roomkey also offered isolation and quarantine. So in the prior slide, what it meant was it offered people to come indoors and stay there until the program is expiring. And it is beginning to expire in many places in California. The isolation and quarantine was often run in the same programs, but separate, which is the idea here was to provide non-congregate settings like hotel rooms or trailers for those who require either isolation during COVID infection or quarantine due to the exposure to COVID or symptoms suggestive of COVID, with the goal of reducing unnecessary hospitalization and reducing COVID's community spread. Next slide. So how does Project Roomkey work? Hotel rooms were leased generally by county governments with the promise of FEMA and state reimbursement. FEMA was contracted and agreed to pay up to 75% of qualifying expenses. This did not include services, but in general included things like the room costs, as well as the cost of meals and other essential services. However, this cost for people who met the FEMA definition, these costs were not given up front, and basically the counties need to put the money out and then recover the costs later. Generally, they had on-site staffing by community-based organizations or government employees, and healthcare services bridged often through local health departments or FQHCs. Next slide. This was a slide from the very early days of the pandemic, before we knew much, when we at the Emergency Operations Center for the state of California were trying to sketch out how we could quickly identify people who were either high priority for isolation, those who went into what wound up going into the shelter-in-place hotels, or those who were infected or exposed to COVID. Next slide. After the Project Roomkey happened, and about 15,000 people have been brought indoors. In fact, there are 15,000 rooms, about 22,000 people over the course of the project. California decided to turn to something which they named Project Roomkey, where they sought to identify vacant units, either apartments, hotels, motels, dorm rooms, other things that could be purchased and turned into permanent housing. These were meant for individuals or families experiencing homelessness or at risk of experiencing homelessness and impacted by COVID. Next slide. Roomkey has been administered by the California Department of Housing and Community Development, which made $800 million of grant funding available through the Federal CARES Act and through the state of California threw in an extra $200 million to bring it up to $800 million. Local public entities rapidly applied for funding, and with the caveat that all funds had to be used by December 30th. So there were these rapid funding rooms, and counties had to identify potential sites, bid for them, and if they could use the funding by December 30th and met other requirements, they could be offered these funds. Next slide. Some other emphasis, other ways to treat it were the eviction moratorium. I spoke earlier about the CDC eviction moratorium. That was backed up by states and local governments that issued separate moratoria. However, none of these cover back rent, neither the CDC eviction moratorium or the state and local ones, and they don't cover those living in formal situations. So we've seen many people leak out into the streets because they don't actually meet criteria to be covered by these moratorium. Together, they've likely prevented hundreds of thousands of evictions, but without rent relief, we fully expect a wave of evictions to come. And I want to remind everyone that although the Biden administration has said that they are likely to act to extend moratorium, the CDC moratorium actually expires on December 31st, leaving a 3-week period in which we could see unprecedented waves of evictions. Because none of these moratorium covered back rents, people have accumulated large amounts of rental arrears that, depending on what state and locality they live in, they may be expected to pay as soon as the CDC moratoria lifts. Next slide. We have tried to come up with some methods to address some of these problems, and I wanted to talk briefly about our efforts to address the problem of testing in homeless communities. We at UCSF have worked closely with our community as well as the San Francisco Department of Public Health, led by community advisory boards, working closely arm in arm with community-based organizations, with community health outreach workers, who we call CHOWs. We have done a series of mass testing events, partially to get prevalence of COVID amongst people experiencing homelessness in San Francisco, but partially as proof of concept of how we can successfully bring testing to communities who have not been able to be tested successfully. In these interventions, we had the community health outreach workers who came from the community and had extensive experience in the community. We hired them, trained them, and paid them. And they spent generally about a week before each testing event out in the community, spreading information about testing, taking people's questions and dispelling myths. Many people were afraid, for instance, that if they got tested, the testing would bring them COVID. Many people were afraid that if they got tested and were found to be infected, they would be criminalized, they would be forced to go into a hotel, or worse, into a carceral system. And so a lot of what the CHOWs did was provide information, reassurance, and support. The word of mouth increased participation, and we decided from the beginning that this would be a test and treat operation, meaning that we would not only test people, but we would get information back to them, particularly if they were infected, and offer them whatever services that they needed to be safe. If they wished to go into quarantine or isolation, we would offer them that. But if they wished to stay where they were, we would provide resources to keep them safe where they were. Next slide. What we found worked best was that if we went out into the community, and you can see here from these pictures, we found that setting up a testing site, even if it was just a few blocks away from where people were, was not very effective. Instead, we put backpacks on our testers and we sent them out to street corners with their community health outreach workers and did testing literally where we met people. Teams had a community health outreach worker, a phlebotomist who did the testing, an interviewer who collected data for us, including all of the information that we needed to be able to find people if they were infected. We had physicians and nurses available if people had symptoms or needed medical attention. And we found that this worked significantly better than having a stationary site, which we also tested. It was highly accessible and extremely low barrier. We offered people a $10 gift card, as well as food and information if they were willing to be tested. And we found extremely high percentage of people were willing and eager to undergo testing. And we found it easy with the information we collected to go back with the help of our community health outreach workers and find people who tested positive. Next slide. Non-Congregate Shelter, next slide. And I have spoken a little bit already about Project Roomkey, so I'll skip this. Next slide. Next slide. Sorry, next slide. Next slide, yes. Okay, so where do we go from here? I think the pandemic has raised all of our awareness of the dangers of homelessness and crowded housing. It has raised awareness of the racial ethnic disparities, both in homelessness and in the impact of COVID. We have found that quick action during difficult circumstances, things like action to start things like Project Roomkey and other interventions, prevented what could have been even worse death and suffering. I think the pandemic has made very clear dangers that some of us have had for a long time about the safety of congregate shelters, and has really raised alarms about thinking about, can we come up with new models? Projects like Roomkey have shown it is possible when there's political will to get action to get around barriers to ELI housing creation. However, with all of these things, the scale of the response has not met the need. Next slide. We have grave concerns that as eviction moratoria lift, we're going to see major increases in homelessness. I think that the disparate impact of COVID, disease, economic disruptions, housing vulnerabilities in the Black, Latinx, and Indigenous communities really lay bare the role of structural racism in our communities and our systems and really beg a bigger response. And there's a desperate need for action. It's very important that we don't make the same mistakes we made during the 2008 housing collapse, where many people became homeless, and yet as housing prices dropped, we did not act quickly to reclaim those housing and keep them available for ELI housing, and instead lost them to speculators. There are opportunities now made by decreases in housing costs in some of our highest cost markets, but these opportunities will only be as good as our reaction to them. The lack of Senate action, particularly on the lack of passage of the HEROES Act, the lack of action on passing rent relief, really leave us vulnerable to see dramatic increases in homelessness right at a time when homelessness has never been as dangerous as it is now. Next slide. And I think all of this has left us with a reminder that there is no medicine as powerful as housing. Homelessness has really laid bare and made even more vulnerable this population during this unprecedented pandemic. And it has made perfectly clear the reason and the urgent need for ending homelessness as we know it. And with that, next slide, I'll leave my contact information, and I'm happy to take any questions.
Thank you, Dr. Kushel.
Thank you, Dr. Kushel.
I have a question. Can you tell us how providers are doing at providing psychiatric medications, especially long-acting injectables, for people who are both homeless and have mental illness?
Yeah, I think, I think COVID has made what has been a very difficult problem even more difficult. You've seen some really incredible responses of people doing things like street outreach and trying to bring medication to where people are. But I think what we've also seen are all the fractures in our system or lack of a system. What we've heard from our interviews and research in people experiencing homelessness is they have found this incredibly disoriented. Much of their coping mechanisms have sort of left, right? The ability to drop in to get care as you need it. Now, if you want to go see your primary care doctor, you're much more likely actually to need an appointment, much more likely to need a phone, because they're trying, we as healthcare providers are trying to limit the number of people who we're exposed to. The rapid move to telehealth has been really heralded by many people as, a great new era. And in many ways it is. But to be honest, it hasn't worked terribly well for people experiencing homelessness. So what we have seen is incredible increases in mortality, not necessarily directly related to COVID, but perhaps more directly related to all of the disruptions in substance use treatment, reductions in harm reduction efforts, reduction in access to care for things like mental health and other physical health problems. And so I think that the answer is people are doing their best. We're seeing heroic outreach efforts of, outreach nurses and physicians going out in full PPE into encampments where they can or into shelters. But to be honest, what we're actually seeing is a major crisis caused not only the direct harms of COVID, but in many cases the indirect harms, whereas the healthcare system is really stressed to the max and is not really meeting the needs of the moment for this population.
Thank you. Our next question says, I'm a peer specialist from Benton County, Oregon. How are peer services being utilized? Have they been more effective during this time of crisis?
Yeah, I think that we've seen peer services as actually being the bright point here. I think there have been challenges because, many of the people who are peers are also struggling under the weight of the pandemic. Children are out of school. They may be facing their own health crises or economic crises. I think it was difficult to get people protection in the form of adequate PPE. On the other hand, what we've learned loud and clear is both for an effective response for things like testing, and I think it's going to be incredibly incredibly important when we move into the next phase of vaccination that we fully engage peer support. I think there has never been a more important time. What we learned, for instance, from the testing is that in many of the arenas where we have been doing these testing interventions, there were testing sites that were open and just not being used by this population. When we really partnered with peers who went out and built trust in the community, it was incredibly effective. And I know that we plan to expand our use of peers or community health workers, whatever you may call them, in everything that we do. And I think peers are going to play an incredibly important role in efforts to get vaccinations to this population as well.
Thank you. Our next question says, I'm curious how COVID is affecting homeless individuals who have to register as sex offenders and those on parole or probation. Have services or programs been reduced or eliminated?
Yeah, I think what we're seeing is services, have been doing in some ways a remarkable job to do all that they can under nearly impossible circumstances. But I feel like the Ginger Rogers sort of backwards and in high heels, everything has been so much more difficult. In many places, the percentage of people in shelters have gone way down because the shelters have needed to de-intensify, sort of scattering people to different places. Places that relied on volunteer help found that their volunteers dried up. And many of the outreach workers and things are really facing enormous risks themselves to provide services to this population. I think in some ways the untold story of COVID has been all of the secondary and less appreciated effects because of the lack of, sort of the breaking up of what was already a pretty fragile safety net.
Thank you. We have a question from Professor Lamandry of Linfield College. They say, I'm seeking people who are homeless and have mental illness showing increased paranoia and fearfulness with the COVID and with social unrest. They have been pushed out of their places to live on the streets by demonstrators and distrustful of organizations and government. How are faith organizations filling this gap?
Gosh, that is a very good question, and I'm not sure I know the answer exactly. I think, different organizations are doing different amounts of work, but I think your point is very well taken, that this is a time of incredible anxiety for us all. And I think if people had a tendency to be fearful, there is a lot of reason to be fearful now, and there's a lot of reason to be distrustful. I think that that the messaging from the government has often been very difficult. And I think that we have certainly seen people's social isolation increase, people's distrust increase, and I think for good reason. And so I think people's, have a lot of anxiety, and I think there's certainly a lot of need for us to come together. I think there's going to be a lot of need for targeted support and outreach to what is now an extremely vulnerable, very fearful population. We have found, by the way, that when we go out and we're in PPE and we're wearing masks and face shields, it certainly doesn't do a lot to promote people feeling comfortable if someone was already, had some paranoia or anxiety. And so I think this is, again, going back to the person who spoke about peers. It really raises up the importance of communities that are closest to the problem being given the resources that they need to get us closer to a solution. I think this is going to be extremely important as we head into this next period, where, first of all, we're going to see large numbers of people at risk for homelessness, and so potentially large increases in homelessness, as well as we're going to need to really get large uptakes in vaccination from a population that might have very good reason to not trust these vaccinations. So I'm certainly hoping that we can rely on community partners to really be given the resources that they need to take the lead, because I think that's where we're going to get the trust from.
Thank you. Our next question says, we saw a drop in arrest of houseless people in April and June to depopulate jails. And now, in the third quarter, a resurgence and jails are full again. What did we learn from the springtime depopulation of jails?
Yeah, that is a great question. I had the honor and the privilege of working with the National Academy of Medicine to write a report basically urging decarceration, because jails and prisons have turned out to be probably the single most dangerous place we have in terms of risk of COVID. And what we learned when there was depopulation of jails and prisons is we did not see a resultant, increase in crimes or other things. What we saw was less people placed in danger. I'm quite concerned for any resurgence of jail populations. I just don't think, I think we, no matter what you think about incarceration more broadly, and the role that it plays in society, incarceration during this period of the pandemic is extraordinarily risky. And it places at risk not only the people who are incarcerated, which certainly are at the center of the risk, but also the staff members who work with them and the community at large, because we see this as being a sort of outside in, inside out problem where there is movement between carceral spaces and the general community. We've seen many prisons are actually in rural areas where when they have had large outbreaks, it has overwhelmed an already stressed health system. And we've seen many, many vulnerable people become infected and die. And so I think that what I would really hope is that this is another moment of awakening and a chance for us to reckon with our tendencies to incarcerate such large numbers of people, why we do it, and what the harms are.
Thank you. When do you see people who are homeless and unsheltered getting access to a vaccine?
That is a really great question. I would advocate that people who experience homelessness should be considered to be, in one of the very high-risk groups that hopefully will get earlier access to the vaccine than the general population. You've seen different schemas put forth, with essential frontline health workers in the very first group, and then with several other groups right behind them. I certainly hope that we see people experiencing homelessness placed very high up in that prioritization scheme. I also think, though, that we need to be extremely thoughtful on how we do this. This is a vaccine that actually it's almost certainly going to need a series of 2 vaccines to be effective. It's a vaccine that will have some side effects that could very easily scare people. And I think we need to realize that the healthcare system has not really engendered trust from the communities most at risk for homelessness. And there could be reason for people to be quite frightened of the vaccine. So I think it presents 3 issues. One is, how will people who experience homelessness be placed in the prioritization scheme? I think that is still being discussed. I think because of the very high risk of congregate settings, for people who are going to be in shelters, it seems like they should be at the very top of the list. I would argue that people who are in unsheltered settings where they seem to be at lower risk of acquisition of COVID, for other reasons should be near the top of the list as well. I think it creates a pragmatic issue of how we do this vaccination. And I, really hope that each state, as they are determining their vaccination strategy, that they are engaging people with expertise in homelessness. And by expertise, I mean people with lived expertise of homelessness, as well as those who work with them, to think of how we are going to come up with a strategy to effectively bring vaccines to this population and to support the population through this extremely important initiative. We have been doing a fair amount of work talking to people experiencing homelessness about their willingness to get vaccinated and their concerns about it. We're seeing relatively high acceptance of vaccination, although many of the same concerns as we would expect to see. And as I said before, I think that we need to not only prioritize this population, but be smart about how we reach this population. It's going to be a very difficult problem logistically, but I think it's a problem that really needs to be solved by those closest to the problem.
Thank you. Our last question is, what do you see coming from the Biden administration in the first few months?
Yeah, I mean, I think a lot, to be honest, is going to depend on the outcome of the upcoming Senate races and whether there, we can get Senate buy-in for some of these things. I see a commitment to on day one. Extending eviction moratoria. The Biden administration has put out a very exciting housing platform, including, fully funding for vouchers. Whether that happens or not, I think really depends on the Senate. I think that we desperately, desperately need COVID-related rent relief and economic relief. And I think that's going to be extraordinarily important. I think it's really a time, what we have seen time and time again with homelessness is that when there is actually a federal commitment to it, we see success. You see that in the Veterans Administration, where veteran homelessness has decreased year over year as there's been sustained funding and a reliance on evidence-based practices. I think that with the Biden administration, I have some hope that those practices will be taken up again. Housing first, fully funding vouchers, supporting the creation and the production, the preservation, and the protection of extremely low-income housing. I think that we need economic relief, and I think we need to be creative about how we, get healthcare to those who most need it as well. So I am certainly hopeful, but I think a lot will actually depend on whether the Senate is willing to go along. I think there are some things that the Biden administration can do on day one, no matter what the Senate says or does. And I think we will see, for instance, an immediate action on things like eviction moratorium. Eviction moratorium are good, but what's a lot better is if we can get rent relief to go with it. And I think that is yet to be seen, whether they can get that passed through Congress.
Great. Well, thank you so much for sharing your knowledge with us today and answering these questions.
Great. Thank you for having me.